You finally do the responsible thing. You schedule the bone density scan, you show up, lie still for a few minutes, go home, and then your patient portal lights up with words that instantly change the mood in the room. Osteopenia, osteoporosis, elevated fracture risk. Maybe your doctor reassures you. Maybe you get a prescription right away. You take it faithfully, and then months later, you realize something that's hard to admit out loud. The fear didn't go away. You still walk downstairs differently. You still scan sidewalks for ice. You still do that quiet math in your head. If I fall, do I break? Or you know someone who did everything right and still broke a wrist, a vertebrae, a hip. That's when confusion turns into frustration, because osteoporosis often gets treated like high blood pressure. Pick a medication, take it, and move on. But bone doesn't behave like blood pressure. Bone is alive. It's being broken down and rebuilt every day. Your skeleton is more like a house under constant renovation than a solid block of concrete. And if you're in your 40s, 50s, 60s, or beyond, especially after menopause, or after years of certain medications like steroids, or with certain medical conditions, that renovation can tip the wrong way faster than most people expect. And yes, men get osteoporosis too, so don't tune out if you're not a postmenopausal woman. Here's the part most people never get told in plain English. If the house is already structurally compromised, simply slowing down damage doesn't automatically make it sturdy again. So let me ask you a question that changes how you understand everything that comes next. If you only try to maintain something that's already weak, what happens? Usually it stays weak, or it improves so slowly you still don't feel safe. And if your risk is already high, slow improvement can leave plenty of time for fractures to happen. Now listen closely, because this explains why two people can take the osteoporosis medication and end up with completely different outcomes. The mistake isn't always the medicine. Sometimes the mistake is the order. Some treatments are designed mainly to hold the line, to reduce how fast you lose bone. Other treatments are designed to rebuild, to push your body to form new bone when risk is high and time matters. When everyone gets treated the same way, you're not just choosing a drug, you're choosing a strategy, whether anyone calls it that or not. Most of the time, nobody explains it as strategy. It gets presented like a product menu: weekly pill, monthly pill, injection, infusion, covered, not covered, prior authorization, step therapy. Meanwhile, you're thinking, okay, but am I actually safer? Here's what drives me crazy about how osteoporosis gets handled in America. The system often pushes a bisphosphonate first default like it's the only opening move that counts. You walk in with a diagnosis, you walk out with a weekly pill, and the most important question gets skipped. Are you the person who needs to build bone aggressively right now, or are you the person who mainly needs to protect what you have? That isn't a small distinction, that's the entire game. And it's not because clinicians don't care, it's because the system rewards default thinking, short visits, insurance rules, and the easiest first step. For some people, that first step is perfectly reasonable, but for someone who is already fractured, or has very low bone density, or is falling, or lives alone, default care can be the difference between staying independent and losing it. Let me make that real. Margaret is a composite of many patients. She was 56, postmenopausal, and her spine T-score was in the osteoporosis range. She was scared, but she was also disciplined. Her doctor started a weekly bisphosphonate. Margaret did everything right, same day every week, upright afterwards, no shortcuts. 3 years later, her scan barely moved. She was told, keep going, it's preventing further loss. Then she slipped on wet leaves in her driveway and fractured 2 vertebrae. She asked the question so many people ask, almost angry through tears. I did what I was supposed to do. Why didn't it work? And here's the hard truth. The medication may have worked exactly as designed. It slowed bone breakdown. But Margaret wasn't someone who only needed to slow the loss. She likely needed a rebuild phase first because her starting structure was already compromised and time mattered. That conversation should have happened on day 1. It didn't because the system thinks in prescriptions, not phases. So let's build a simple mental map without turning this into a medical lecture.
Imagine your skeleton is an older home. Damage doesn't arrive in one dramatic afternoon. It accumulates quietly. By the time you notice the floor feels off, something underneath has already changed. Now imagine you call a contractor and say, "Fix my house," and the contractor says, "No problem, I'll stop further damage." That can help, but if the beams are already compromised, stopping damage isn't the same as making the house feel safe. That's why the real question in modern osteoporosis care isn't only which drug, it's what phase are we in? Because osteoporosis isn't one single situation. There are different risk levels and different goals. Sometimes the goal is reconstruction, build new bone when fracture risk is very high. Sometimes the goal is protection, stabilize bone and prevent backsliding. And sometimes the goal is course correction, because what you started with didn't match your real risk. Here's the simplest way to understand almost everything you've heard about osteoporosis medications. Most options fit into two buckets. Bucket 1, build bone. Bucket 2, protect bone. And the part that changes outcomes isn't just picking a bucket, it's choosing the right bucket first and having a transition plan from one to the other. In a minute, I'll give you those buckets in plain English and the one concept that turns them into a real plan. But first, I want to ground this in reality. The phased approach isn't just a personal opinion. Major clinical guidance recognizes risk levels and supports considering bone-building therapy for people at very high fracture risk, followed by a bone-stabilizing therapy to maintain gains. And large clinical trials have shown that in higher-risk populations, starting with a bone-building phase and then transitioning to protection can reduce fractures more than starting with protection alone. Quick translation to real life. If you're very high risk, protect what's left may not be aggressive enough at the beginning. You may need a rebuild phase first, so protection actually has something stronger to protect. Now, one important note, every medication has benefits and risks, and not everyone is a candidate for every option. Some choices depend on your medical history, including cardiovascular risk for certain therapies. This isn't about fear, this is about matching the strategy to the person. And exact numbers vary by study and population, so always review the specifics with your clinician. Okay, now the buckets in normal human language. Bucket 1 is build bone. Think reconstruction. These therapies stimulate bone formation more actively, usually for a limited window, often about 12 to 24 months. The goal is to strengthen fast enough to matter when risk is urgent. Bucket 2 is protect bone. Think stabilization. These therapies reduce bone breakdown and help you keep what you have. And just as importantly, they help you hold on to what you just built. So the argument isn't which is better. That's like arguing whether reinforcing beams is better than locking doors. You need both, but not always at the same time, and not in random order. Here's a reflective question that tells you whether you were given a strategy or just a default. Has anyone ever told you what phase you're in, or did they just hand you a prescription and hope the label would do the thinking? If you've never heard high risk versus very high risk, and you've never heard build first versus protect, you might not have been given a strategy, you might have been given the system's default. So how do you tell, without playing doctor on the internet, whether you might need a rebuild first conversation or whether protect first makes sense? Think in profiles. First profile, something already broke. If you've had a fragility fracture, meaning a fracture from a fall from standing height or less, your bones have already proven they can fail under normal life. That doesn't mean panic, it means urgency. Not panic, urgency. Because the goal isn't just nicer numbers on a scan. The goal is fewer fractures and preserved independence. Second profile, the structure looks very thin. If your bone density is severely low, or you've had multiple vertebral fractures, or your clinician used words like very high risk, that's another sign you may need more than a slow, incremental approach up front. Third profile, falls are part of your story. If you've fallen more than once, feel unsteady, have vision issues, or take medications that cause dizziness, your fracture risk can be high even if your scan isn't the worst you've ever seen. Osteoporosis risk is bone strength plus fall probability.
A great medication can't out-medicate slippery socks on hardwood floors in a dark hallway at night. And here's a reality check that most people ignore because it isn't a prescription. Falls are common, especially as we age, and many falls are driven by fixable factors. Medication side effects, low blood pressure when standing up, poor lighting, loose rugs, untreated vision problems, and simple muscle weakness from not training your legs. So when someone tells you just take this pill, but nobody talks about your balance, your vision, your home setup, and your strength, you're missing half the plan. Fourth profile. You followed the plan and nothing changed. If you've been on treatment and you're still losing bone or you fractured anyway, that doesn't automatically mean you failed. It can mean the phase didn't match the moment. It can also mean there are secondary causes or absorption issues that haven't been addressed. Let me give you the contrast story because it shows what sequencing can look like when it's done deliberately. Robert was 62 with a very low spine T-score and a vertebral fracture that happened during normal life. His clinician started him on a bone-building therapy first, then transitioned him to a protective therapy to lock in the gains. Years later, he stayed active and avoided another fracture. That's not magic, that's a phased plan. Rebuild when the structure is fragile, then protect so it stays strong. Now here's the practical part most people never get, the workup. The scan is the headline, the why is the story, and the story changes the plan. So here's a calm, TTS-friendly workup you can discuss with your clinician, spoken as a plan instead of a lecture. First, confirm the baseline properly. That usually means a DXA scan of the hip and spine, sometimes the forearm, plus making sure you're comparing apples to apples if you have prior scans. A T-score is a comparison to peak bone density, but context matters. Your trend, your fracture history, and your fall risk can matter more than a single number. Next, translate the scan into real-world fracture risk. Many clinicians use FRAX, a tool that estimates 10-year fracture probability, but the number is only as good as the information you feed it. Your personal history matters. Fractures, recent falls, steroid use, early menopause, family history of hip fracture, smoking, alcohol use. Then look for secondary causes of bone loss, because this is where a lot of people quietly leak bone no matter how healthy they are. Vitamin D deficiency, thyroid problems, parathyroid issues, kidney disease, malabsorption, including celiac disease in some people, low testosterone in some men, certain medications. The point here isn't to turn you into a lab expert. The point is to stop treating your bones like they're failing for no reason, when sometimes there is a reason. Pattern interrupt, because I want you to hear this clearly. If you're losing bone for a fixable reason and nobody checks for it, you can spend years arguing about medication choice while the underlying leak continues. That's not a character flaw, that's a missing step. After that, if you've lost height, have persistent back pain, or your clinician suspects silent spine fractures, ask whether spine imaging is appropriate. Vertebral fractures can be quiet. Sometimes they feel like chronic back annoyance until they snowball. Next, assess fall risk like it's part of the diagnosis, because it is. Vision check, medication review for dizziness or sedation, blood pressure changes when standing, simple balance and strength screening, and yes, a quick home safety scan, lighting, rugs, stairs, bathroom supports, and footwear. This step can change your real-world risk dramatically because medication works best when you don't fall. And finally, don't just ask, "What do I start?" Ask, "What's the sequence?" and "What's the transition plan if we have to stop or switch?" Because this is where people get blindsided. Osteoporosis medications aren't only about starting, they're about transitioning safely.
Some therapies, if stopped abruptly or delayed without a plan, can lead to rapid loss of gains and increased spine fracture risk in certain situations. That's not meant to scare you, it's meant to protect you from an avoidable mistake. Real life includes travel, insurance delays, job changes, side effects, missed appointments. Your plan should be built to survive real life. So here's another question that tells you whether you have a true strategy. If your current medication ended tomorrow, would you and your care team already know the next move? Most people don't, because nobody explained the sequence in the first place. Now, I'm going to give you a simple, practical script you can use at your appointment, especially if insurance is part of the problem. You can say, "I understand the standard first step, but can you document my risk category clearly? And can we discuss whether I'm high risk or very high risk? If I'm very high risk, what's the medical rationale for starting with a rebuild phase, and what's our transition plan afterward?" Then, if they mention step therapy, you can ask, "If we have to start with the covered option, what's the threshold that would trigger a shift in strategy? And what do we do if I can't tolerate it or if I fracture anyway?" You're not being difficult. You're asking for a plan that matches biology and protects your future. Now, quick disclaimer because it matters. I'm not your doctor and this isn't medical advice. Osteoporosis treatment is individualized. Talk with your clinician before starting, stopping, or switching any medication. If you've had a fall, a fracture, severe pain, or concerning side effects, get medical care promptly. Now let's land this in a way that actually reduces fear. You are not doomed because you have a diagnosis. You are not fragile as a person. You are in a moment where the right plan, matched to the right phase, can change the trajectory of your next decade. And here's one more thing that doesn't get said enough. Medication is the medical backbone, but your daily decisions can lower fracture risk while the medicine does its job. That doesn't mean you heal yourself. It means you stack the odds in your favor. Strength training for legs and hips, balance practice, adequate protein, getting vitamin D and calcium right for you based on diet and labs, removing the easy fall hazards in your home. These aren't cute extras, they are the support beams around the medical plan. So I'll leave you with one final question, and I want you to feel the answer in your body. If you fell tomorrow, on the way to the mailbox, stepping off a curb, reaching for something on a high shelf, would you trust your bones to hold you? If that question made your stomach drop, that's not weakness, that's a signal. And the good news is that signals can be answered with a plan. Because the moral of the story is simple. The problem is rarely no medication. The problem is treating every skeleton like it's in the same chapter of the same book. Osteoporosis has phases. Treatment should have a sequence, and when the sequence matches your risk, you don't just reduce confusion, you can reduce fractures, preserve independence, and keep living the life you've worked your whole life to build. So here's what I want you to do next, and it's more valuable than a generic like and subscribe. Write down your risk profile in one sentence. Have I had a fragility fracture? Yes or no? Have I fallen in the last year? Yes or no? Was my bone density described as severe or very low? Yes or no? Do I have big risk factors like steroid use, early menopause, or strong family history? Yes or no? Have we checked for secondary causes? Yes or no? And do we have a transition plan? Yes or no? Bring those facts to your next appointment and ask the phase question, what phase am I in? And what's our transition plan? And if you want the next step, the next video goes deeper into what very high risk usually means in practical terms, how to avoid the transition mistakes that erase gains or raise rebound risk, and what a realistic timeline looks like when you do this strategically. Because information without a plan is just noise, but a plan based on your actual risk, that's power.